Hi, my name is Gavin Harris, and on behalf of NETEC, I'm going to be presenting preliminary guidance for high-level containment care of patients infected with Sudan Ebolavirus. I'm an assistant professor of medicine at Emory University in the divisions of pulmonary and critical care medicine, as well as infectious diseases, and I'm also a staff physician for the Emory University Serious Communicable Diseases Unit. Now, my presentation will have three primary objectives. The first, I'm going to give an overview of the current situation in Uganda. We're going to talk about some symptoms and presentation and some differential diagnoses of Sudan Ebolavirus. And then finally, from a strategic level, I'm going to provide some preliminary management guidance for patients requiring high-level containment care. To review the epidemiology of Ebolavirus disease itself, Ebolavirus is a filovirus that was discovered in 1976 in Zaire, which is now the Democratic Republic of the Congo. And it really consists of 6 different species. Now, 4 of those species cause infections in human, and the last 2, which are highlighted in red, do not, to our knowledge at least, cause disease in humans. I've also included Marburg virus and Lassa virus, as well as Crimean Congo hemorrhagic fever virus, because these viruses are close cousins and are often found in patients who have co-infections. Now, Ebolavirus circulates in a reservoir of which we know little about just yet. We believe it to be in specific species of bats in Africa, and it also circulates among wild animals. At a certain point, a spillover event occurs into humans, and this can occur through direct contact with butchering animals. It can occur through direct contact in the wild, and this can spark an outbreak through traditional funeral practices, which are not performed in safe manners of infected patients, perhaps through unprotected healthcare workers, or through the direct exposure with blood and bodily fluids of other humans. We also know that Ebolavirus disease in certain parts of the body, such as the eye and the seminal fluid, can survive for long periods of time, even years. And we know this from survivors of that 2014 to 16 West African Ebola outbreak. In terms of outbreaks by species and size since the discovery of Ebola, you can see the overwhelming majority have been of the primary strain, Zaire Ebolavirus, which was the cause of that 2014 to 2016 West African outbreak in Guinea, Sierra Leone, and Liberia. Sudan Ebolavirus has had some sporadic outbreaks in South Sudan and Uganda, as you can see, and then Thai forest and Bundibugyo Ebolavirus are much less common, at least to our knowledge. Now, in terms of the current outbreak and the current situation, it was first declared an outbreak by the World Health Organization on the 20th of September in 2022 this year, and as of December 5th, we have found that 9 districts in the country have been reporting cases. There have been 142 confirmed cases with at least 20 probable and 55 fatalities thus far. Now, the last case that was announced was on November 27th in a stillborn who was born to a survivor of Ebolavirus disease. And among the confirmed cases, the case fatality rate approximates 39%. But if we add in the probable cases, this is likely much closer to 50%. Additionally, of concern, there have been undocumented chains of transmission. So while the outbreak does appear to be abating, it may not yet be finished. And you can see the outbreak peaked in mid to late October, that is, and then since has tapered off as the year has come to a close. In terms of the gender of patients who've been affected by Sudan Ebolavirus during this outbreak, as you can see, the overwhelming majority have been males in the 20 to 39 age group, though females and women have been affected absolutely. And we've also seen significant numbers of school-age children throughout the country who have been affected as well. Now let's move on to some symptoms and presentations and talk about some differential diagnoses. So there are several clinical stages of Ebolavirus disease. And initially, patients have nonspecific symptoms like fever, weakness, anorexia, myalgias, headache, diarrhea, and vomiting. This is what is considered the early phase or the dry symptoms. It's important to keep in mind too that patients may present at any stage of their illness and may progress through these stages quite rapidly. Following this early phase, and this is usually post day number 7, patients may progress into the late early or peak phase, which is considered those of the wet symptoms or the classic symptoms of Ebolavirus disease that we think about. These are the hemorrhagic manifestations that may lead to renal failure, respiratory failure, or in short, multi-organ failure and death. Now, patients are not considered contagious with Ebolavirus disease before they show signs of symptoms. So day 0, when they show their first symptom, that is really considered the beginning of the early phase and the beginning of the contagious period. Now, as patients progress through these phases into the peak phase, their level of virus in the body increases, which we believe is responsible for most of the manifestations that you will see, as well as a dysregulated host immune response. In terms of the differential diagnosis, so it is important to think that not only may patients present at any stage in their illness, but the majority of patients who have signs and symptoms consistent with special pathogens, so not just Ebolavirus disease, do not in fact have those pathogens. And interestingly, in the United States, the high-risk patients under investigation that we have reported on have in fact been infected with malaria. So malaria is a very important consideration that we need to think about, especially in this part of the region, and we will talk about that more in detail in a moment. Of course, we have to think about other viral hemorrhagic fevers, influenza, COVID-19, of course, and bacterial sepsis, which we again discuss. So in 2020, Uganda, interestingly, had the third highest global burden of malaria cases and death and the fifth highest level of deaths in Africa. So this is an endemic disease that is very common and for which we have to make certain that patients do not have when they present with concerns for Ebolavirus disease. And during the 2016 and 2017 West Africa Ebola outbreak, malaria, in fact, was the most common diagnosis. Almost 50% of patients had this, in fact, followed by acute diarrhea and others by no identifiable agent. Now, the co-infection rate with Sudan Ebolavirus and malaria in Uganda is unknown, but given the high prevalence of malaria, we have to assume it also is quite high. So for these patients who may present, empiric anti-malarial therapy should be administered until malaria is ruled out. And we do this through at least 2 to 3 rapid screens. We also want to make sure that patients complete their malarial prophylaxis, and treatment itself can be discontinued if malaria is negative or that treatment course has been completed. As you can see, severe malarial symptoms truly represent and are almost identical to those you may see in patients with Ebolavirus disease. Now, in terms of bacterial sepsis or bacterial co-infections, so we know from that West African Ebola outbreak that gut translocation of gram-negative bacteria was actually quite common, and we thought this was a direct result of infection of the colonic endothelium and epithelium, broke down the gut lining and increased the ability of bacteria to translocate. And so because of this, empiric antimicrobial therapy was administered and is advised to be administered by the World Health Organization to all of these patients. However, the true evidence to justify this is lacking. And so from a NETEC perspective, the benefits must be weighed against the risks. And in terms of risks, I'm thinking here about allergic reactions that patients may have. I'm thinking about renal failure that patients may, that this may precipitate from the administration of antibiotics. We're thinking about possible Clostridioides difficile infections and the creation of further antimicrobial resistance. So in fact, the 2021 surviving sepsis guidance here, which are the newest iteration of these guidelines, state that if patients do not present in shock, we can wait in terms of administering antibiotics or other antimicrobial therapy, provided we do further investigative tests. If shock is present, of course, it is completely reasonable and is advised to administer empiric antimicrobial therapy. But keep in mind, if shock is absent, this may be difficult to distinguish whether patients have sepsis or not. Now, if we do decide to administer antimicrobial therapy, we have to cover appropriate community-acquired organisms until this co-infection is ruled out. It's also important to think about, and it's not unusual for Ebolavirus disease patients to develop a new onset fever associated with new leukocytosis after they've already passed through that peak phase into the recovery phase. This follows an initial improvement in presenting parameters, and this may be a sign itself that patients may have, in fact, developed a secondary bacterial infection. We also want to make sure we cover the clinical characteristics of patients, so their age, their severity of illness, the extent of suspected central nervous system involvement. If patients are immunosuppressed, such as patients with HIV and are on antiretroviral therapy, we want to make sure we continue these if able, given drug interactions, and if patients are able to take parenteral therapy. We also want to make sure that we consider empiric treatment of other opportunistic infections that are common in patients who are immunosuppressed and common in this part of the world, such as tuberculosis, cryptococcus, etc. One of the most important things I cannot stress enough, however, is that we want to make sure we stop antibiotics if there is no clinical or laboratory evidence of infection. And we can think about monitoring this through rapid diagnostic tools or other parameters, perhaps themselves. And again, if fever comes on during the convalescent phase of Ebola virus disease after patients have improved, this does suggest a hospital-acquired or nosocomial infection, especially if the viral load has decreased. Now let's move to some strategic high-level overview guidance for patients with Ebola virus disease in biocontainment units. So as some general principles here, in the biocontainment unit, we have relatively limited regular IC level diagnostic testing. And so it's important to consider if we are performing tests, what is the utility of that test result? How is it going to affect our care? Because all the laboratory testing we do requires special handling and laboratory management. We also want to think about the utilization of portable and non-portable radiographic imaging. These should be kept to a minimum and heavily protocolized. And so I cannot stress enough that specific institutions should investigate how they may handle these patients prior to them actually receiving one. For invasive procedures, we want to think about an early and elective approach to performing these. We want to avoid emergent situations because they pose a greater risk of harm to the operators who do these procedures and also to the patients themselves. If procedures are done, we will also want to make sure that the most experienced operators are the ones who perform them. Now, patients progressing through the various stages of Ebola virus disease, again, as I mentioned, have nonspecific early symptoms, but these may rapidly progress to multi-organ failure and hypovolemic shock and those hemorrhagic manifestations. And it is these that are truly the leading cause of death in patients. We want to make sure we follow our guidance in terms of intravenous fluid resuscitations. These patients may lose up to 5 to 10 liters per day of fluids. They may be intravascularly depleted as well as extravascularly hypervolemic due to low albumin as well as severe vascular damage from the virus itself. And so one of the most important things, if not the most, is aggressive fluid resuscitation and good critical care support. We want to make sure that we aggressively correct any electrolyte deficiencies or abnormalities that may be present. We want to make sure that we have good symptomatic management of fevers and gastrointestinal symptoms, but we want to avoid things like NSAIDs and aspirin because of their interference with the coagulation cascade. And again, we want to think about early intubation and mechanical ventilation if that is a direction that patients are unfortunately heading towards. And we will discuss the others in a moment. I wanted to just take a moment to mention some preventative medical countermeasures that we have. As you can see, for these special pathogens, they are not many. For Sudan Ebolavirus, we only have several that have reached clinical testing. There have been 24 platforms that have been in development. 3 have currently been deployed, the first 3 that you can see on your screen, to Uganda itself. The first one is manufactured by Merck using the same platform as their now FDA-approved Zaire Ebolavirus vaccine, using a vesicular stomatitis vector. And the other 2 utilize an adenovirus vector. The second one actually is a 2-dose vaccine, which does not make it ideal for outbreak control. And the third has also been employed, newly discovered. The fourth platform has entered phase 1 testing, but has not yet been deployed on a large scale. In terms of therapeutic medical countermeasures for Sudan Ebolavirus, we really only have one, which is a monoclonal antibody that is in fact considered a pan-Ebolavirus cocktail for Zaire Ebolavirus, Sudan virus, and Bundibugyo virus. And it binds to viral glycoproteins. It's a 2-dose cocktail that has actually demonstrated efficacy in non-human primate studies and has also been deployed in Uganda as of December 2022. Now, remdesivir, we are also still trying to find a true home for. It has uncertain efficacy against Sudan Ebolavirus, but it also has been deployed during this outbreak. In terms of central venous access, there are several considerations to make. And here, when I refer to central venous access, I'm not just referring to the placement of central venous catheters, but also to peripherally inserted central catheters or PICC lines, or even Hickman catheters as well. We want to make sure that decisions on whether to place any of these devices for access are truly patient-centered and take into account several things. We can think about patients who have difficult intravenous access for anatomical reasons. If we're thinking about delivering caustic medications such as concentrated potassium chloride, because again, these patients will have electrolyte derangements. If these patients will have multiple non-compatible infusions or need frequent venipuncture testing, these patients may be good candidates for central venous access. It's important to think about that vasopressor usage alone is not necessarily an indication for central line insertion. So that is something I think we need to understand and to highlight here. In terms of site selection, we want to prioritize the left internal jugular vein, followed by the left subclavian vein, followed by the right internal jugular vein, the right subclavian vein, and ultimately either femoral veins. We want to avoid the femoral veins at all costs if we can, due to possible risk of contamination from diarrhea and other bleeding complications these patients may have. And we also want to try to avoid the right internal jugular vein and to preserve that for possible vascular access for hemodialysis if it becomes necessary. Timing, of course, should also be assessed on an individual basis, but in general, we like to do things earlier rather than later. In that early phase of illness, viremia is less and coagulopathy is less too. And so by delaying insertion, we increase the risk for both of these things and increase the risk for complications, possible PPE contamination, and operator harm. For all procedures here at NETEC, we do recommend 2 providers in the room for invasive procedures for assistance. We also recommend the utilization of ultrasound, as well as wire transduction and venous manometry to assist in placement confirmation. We'll talk about radiographic imaging in a little while. In terms of airway management, so the World Health Organization in their Ebola treatment units in the field does encourage the use of non-invasive positive pressure ventilation delivery devices such as bilevel or BiPAP and heated high-flow nasal cannula such as Vapotherm Optiflow. But the rate of dispersion of viral particles with these agents is truly unknown. More research in several biocontainment units throughout the NETEC organization is currently underway, and it is important to think that there is the potential for increased aerosol generation. So if any of these devices are to be used, even while they are negative pressure biocontainment units, we do recommend the use of viral filters. Intubation itself is considered one of the highest aerosol generating procedures that is performed. Of course, this must be done in high-level personal protective equipment. Again, we want to think about an early and elective approach. For intubations, if feasible, we do recommend that there are at least 3 personnel inside the room, 1 to perform the procedure, 1 to assist, and 1 to monitor the patient. We do recommend video laryngoscopy, otherwise known as indirect laryngoscopy, over direct laryngoscopy. And the reason for this is that the usage of video allows us to have an increased distance from the patient. It decreases the risk of personal protective equipment contamination. But it is also important to think that if there's hemoptysis or emesis present, this may impair the imaging that we may acquire with indirect laryngoscopy, and so that it is important to have backup plans with appropriate provider skill sets as needed. We recommend that true rapid sequence intubation and neuromuscular blockade is performed, again, to reduce complications, especially from encephalopathic patients, patients who are actively having emesis, hemoptysis, and this will decrease the risk of aerosolization of respiratory particles. We do not recommend attempting mouth opening until patients are fully unresponsive to stimuli. This is, again, to avoid trauma to the operators, specifically bite trauma and PPE compromise. As I mentioned, we want to make sure we have backup plans and procedures in place. We also want to make sure we have additional support personnel in anterooms or outside the patient's room in times of need. And for confirmation that the endotracheal tube has been placed appropriately, we have several parameters at our disposal, including bilateral chest rise, endotracheal tube condensation, quantitative and qualitative carbon dioxide capnography, as well as ultrasound usage too. Now, chest X-ray, of course, may be used if it is heavily protocolized and if it is in accordance with the institution's infection prevention parameters. As I have mentioned, patients may have marked electrolyte abnormalities and deficiencies, including hypokalemia, hypocalcemia, and hyponatremia. We want to make sure that these are aggressively replenished. This may require intravenous and oral rehydration and replacement. In terms of nutritional status, Parenteral nutrition or oral nutrition is preferred. We also want to consider adjunctive antiemetics if needed. Oral rehydration solutions are useful. These are well studied in Ebola virus disease patients, especially in the field. And if nasogastric tube placement is required, we recommend to consider the smallest bore catheters possible. Again, this is to avoid any sort of trauma that may induce coagulation problems, and to confirm placement with either ultrasound and chest X-ray with caveats that we've already mentioned. Now, data from the West African Ebola outbreak suggests that acute kidney injury does occur quite commonly, and it results from multifactorial causes, including hypovolemia, as well as intrinsic renal disease or acute tubular necrosis from hypovolemia, hypotension, and quite possibly direct viral infection itself. We recommend, not only from an infection prevention standpoint, but also from a benefit standpoint, of continuous renal replacement therapy over conventional hemodialysis. As you can see, renal replacement therapy uses much less effluent than conventional hemodialysis, 48 to 96 liters per day versus almost several times that 192 liters for just 1 4-hour intermittent hemodialysis session. Now, we also know from data from that same outbreak that all renal replacement therapy effluent is non-infectious, or at least should be non-infectious. We have found that the viral particles are too large for the hemodialysis membranes. We have tested this multiple times by PCR for confirmation. And what this allows for is the disposal in the same manner as local guidelines require for stool or urine waste for these patients. In general, procedures and testing, as I mentioned before, should be used judiciously and with consideration of the utility of the result. We want to consider bedside ultrasound where possible to limit the potential spread of Sudan Ebolavirus disease. We want to consider dedicating a portable general diagnostic ultrasound device to our biocontainment units, of course, when and where resources allow. But ultrasound can really be used to examine any organ system of the body, as well as for procedural guidance and confirmation of placement. Cardiac arrest care is an area that is undergoing significant research at several biocontainment units across this country. But as a general rule or general principle, we recommend that there are procedures in place as per institutional protocol prior to the acquisition of patients. We want to make sure we involve all of the stakeholders to engage in discussions regarding the feasibility of cardiac arrest care and the utility of performing resuscitative efforts. We want to think about reversible situations versus those that may not be reversible, and perhaps if patients are in multi-organ failure and on the brink of collapse. We want to think about these things from not only an operational standpoint, but also from an ethical standpoint too. Several sites are considering the use of automated devices such as the Lucas chest compression system to decrease patient contact and possibly reduce the risk of healthcare worker injury, PPE compromise, and aerosol generation. But I do want to highlight that this is an area of ongoing research. Now, during cardiac arrest care, when and where resources allow, again, we do recommend a minimum of 3 providers inside the patient care room. One of those should be an airway competent provider, ideally a critical care trained physician. One who is an invasive procedure competent provider, such as an advanced practice practitioner, and 1 to 2 critical care nurses. We also recommend that there are a minimum of 2 nurses stationed outside the patient care room to assist, or other healthcare personnel that can also assist. We want to consider the utilization of a critical care trained physician to direct resuscitative efforts from afar, perhaps, if communication devices and visualization allow for this in the biocontainment unit. We also want to recommend that routinely performing procedures that require deep physical manipulation, such as the placement of chest tubes, emergent surgical cricothyroidotomies, are not performed during cardiac arrest situations. Again, this is to limit the spread of aerosols, to limit the spread of virus, and also to reduce the risk of possible harm to operators themselves. Now, more guidance will be forthcoming, but we have reached the end of our presentation. So I wanted to encourage you all to join our conversation. Please email us at info@netech.org. You can check out our website at netech.org for further healthcare-related resources, as well as visit us on various social media channels. It's been quite an honor and a pleasure to speak with you today.